Hello everyone and welcome back to Many Notes for Medicals. We are here with another topic known as gangrene from general surgery. So we'll be dealing with the introduction, the causes, classification, dry and wet gangrene, gas gangrene, diabetic gangrene, fournier gangrene, internal gangrene, and then we'll go through a summary of it. Okay. So, what is gangrene? So, gangrene actually it's a macroscopic death of the tissue in situ. It can occur in continuity with the adjacent viable tissue along with putrefaction. So when putrefaction occurs, there will be loss of function over there too. So what are the most common sites you can see this gangrene? It's found in limbs, appendix, bowel, testes, gallbladder, etc. So what are the causes? It can be secondary to arterial occlusions, like in the cases of atherosclerosis, emboli, diabetes, TAO, Raynaud's disease, ergots, etc. It can be due to infections, infective causes like boil, carbuncle, gas gangrene, fournier gangrene, cancromoris, etc. When it comes to traumatic, it can either be caused by direct trauma or indirect trauma. Physically, it can be caused by burns, scalds, frostbite, chemicals, irradiation, electrical, or venous gangrene also can be another reason of it. So the classification is basically gangrene is divided into dry gangrene and wet gangrene, as well as traumatic, in which this wet gangrene is divided further into gas gangrene, diabetic gangrene, fournier gangrene, and internal gangrene. So this dry and wet gangrene, when we see the dry gangrene, no, you will be seeing a very what can I say? It shows a very gradual slowing of the bloodstream, and it leads to very dry, desiccated, wrinkled, mummified look. It basically occurs by the aseptic ulceration with minimum infections. So if you can see over the pictures over here, you can see that this is an example, this is a classical example of dry gangrene. Then we go through the wet gangrene. So in wet gangrene, what happens is here the septic ulceration, no, it occurs because of it, and so demarcation is very vague with skip lesions, um, and it leads to proximally very high levels of amputation. And then even after the amputation, what happens is the skin flap, no, it slowly die back in process, and it sometimes leads in the failure of the amputation. So it occurs along with the super added infections also. So due to the infection with the putrefaction, it causes an edematous swelling. It has a discolored part and it spreads proximally with vague line of demarcation from the adjacent viable tissue. If you can see over here, this is a classical example of the wet gangrene. Now we'll be seeing the differentiation between it. So one differentiation over here is about the what happens over here is you can see that the site over here, it would be mostly in the lower limbs, and in wet gangrene it's most common in what I said was bowel region, testicles, and all those regions. Okay, in mechanism, what happens is because of the arterial occlusion, the dry gangrene usually occurs, while in wet gangrene what happens is mostly dependent on the venous occlusion, but it can also often occur because of the arterial occlusion, though it is rare. In microscopy, what we see is this dry gangrene, no, it is found dry, shrunken, and black in color. It looks like a mummified skin. And then for the wet gangrene, you'll be seeing it is moist, soft, swollen, and dark. And also you'll be seeing edematous, putrefied discoloration due to hydrosulfide gas in it. So there is line of demarcation in the dry gangrene and between in the dry gangrene between the gangrenous and the healthy part, while in wet gangrene you'll be seeing no line of demarcation. And what happens over in dry gangrene is slow and gradual blood supply loss is there, but for wet gangrene, no, you'll find sudden loss of the blood supply. And this separation that we see, the line of demarcation that we see is because of aseptic ulceration. So the presence of bacteria actually is very less, and it fails to survive. Bacteria, it fails to survive. But the wet gangrene over here, no, its septic ulceration causes the separation, and because of this, what happened, numerous bacteria is present. So what results over here, what is the result of this thing actually is that dry gangrene would be having a better prognosis on comparison with the wet gangrene, because wet gangrene would be having profound toxemia in it. So this dry gangrene, no, it would limit itself to the demarcation, while the wet gangrene, it will spread fast and very rapidly. So this can the dry gangrene, no, it can be caused by atherosclerosis, thromboanginitis obliterations, which we say as TAO, and wet gangrene, it's usually caused by trauma and emboli. So this over here, you can see this is a line of demarcation, and this is the toe that we were talking about, which looks like a mummified way. It is very dry, shrunken, and blackish in color. So this is a dry gangrene. When we see over here, we can see that it is edematous, it is putrefied and discolored, okay, and it is moist, tender, soft, and swollen. So what are the clinical features? You'll be seeing the color changes in it. Okay, so what are the color changes that you'll be seeing over here? You'll be seeing a pallor, grayish purple, brownish black due to disintegration of the hemoglobin to the sulfide. Then you'll be seeing the absence of pulse, loss of sensation, loss of function. There will be a line of demarcation between the Y-apple and the dead tissue by a band of hyperemia and hyperasthesia, along with the development of a layer of granulation tissue in what? This is seen classically in dry gangrene. Then you'll be finding proximal ischemic features that would be present with rest pain, color changes, hyperasthesia. These are also known as pre-gangrene changes. Okay. Now we will go for the investigation. So what are the investigations we do for it? For hemoglobin, we need to do the hemoglobin and blood sugar testing. Then we need to go for the arterial Doppler angiogram, which by the Seldinger technique, and we can do the CT angiogram. Then we need to do the US abdomen to find the status of the aorta. So over here you can see this portion. Actually, they show it's a arterial Doppler of the radial nerve, radial artery, sorry, radial artery. And over here you can see there is a dry gangrene, a gradual loss of blood supply and leading to a dry gangrene formation. So next we'll be seeing the treatment for this. So we have limb saving methods. We have to give them drugs, and then care of the feet and toes should be done. Treatment of the cause is done. We can go for lumbar sympathectomy or mentoplasty based on the need. Then we have the life saving procedures. So for this, we would rely on amputations, below knee amputations or above knee amputations, and different type of amputations are there. We will learn in further videos about the amputation alone. So the amputations are not commonly done. Next we'll be learning about the gas gangrene. Okay, so this is a very interesting topic. I know it's going to be a very long video, but stick to it, stick to me. We are going to complete this topic very fast. So gas gangrene, so do you know what is the other name of gas gangrene? Yeah, so it is usually known as clostridial myonecrosis. It is also known as clostridial myonecrosis, and it is an infective gangrene, and it is a form of wet gangrene. So what are the source and the predisposing factors? We have learned it in microbiology. Usually the source is what? A contaminated or manure or cultivated soils, and intestines are the sources of it. So the most commonly we find this in some sorts of crush wounds following road traffic accidents, after amputations, ischemic limb, gunshot wounds, and we find it as in war wounds. And we have different clinical types for it. We have the fulminant type. Okay, so what is the fulminant type over here too? It in fulminant type we see that it cause rapid progress and often death due to toxemia, renal failure or liver failure, or MODS or arterial respiratory distress. When we go for the massive group, we see that it involves the whole of the one limb containing fully dark colored gas filled areas. When we go to the group type, you find that all the one group of muscles, okay, it occurs the infection of one type of group of muscles, maybe it would be the extensors of the thigh or the flexors of the leg. So this would be involved in it. Then we go for the single muscle. In that single muscle, it affects only one single muscle in it. When we go to the subcutaneous type, it involves only subcutaneous tissue. Example, the superficial, that is the what happens over here, the superficial involvement occurs, and it may spread and it would involve the whole of the facial planes. This causes necrosis, and the smell is a very foul smelling seropurulent discharge. Okay, then I'll be learning about the toxins of it. So Clostridium, Clostridium velki toxins are alpha toxins. This is the most common, and then we have the beta epsilon lota phytoxin, which causes the myocardial depressant. What is it? Phytoxin causes myocardial depressant. Kappa toxin, this causes destruction of the connective tissue and the blood tissue. Then we have the bursting factor and the circulatory factor. Okay, so now we'll be learning about the pathogenesis of it. So what happens in the pathogenesis is that there is the entry of the clostridial spores through devitalized tissue, commonly in road traffic accidents, crush injuries, surgery, etc. And what happens over there is that an anaerobic environment is created. So what happens over here? Then what happens over here is there would be ischemia, necrosis, and hypoxia. So there is an anaerobic situation formed over here, and then what happens is spores germinate. The spores germinate, and then they cause the multiplication by the vegetative cells. No, they multiply. So there is a bacterial proliferation, and then the spores again further germinate. And then toxins and exotoxins are released, especially the alpha toxin, which is also known as the lecithinase. It causes extensive myositis, and due to its hemolytic, membranolytic, and necrotic nature. And then we have the hemolysin. It causes extensive hemolysis. Then the hyaluronidase, it causes the rapid spread of the gas gangrene. And proteinase, what happens is it breaks down the proteins in infected tissue. And then what happens over here, this toxins and exotoxins are released. Then we have the carbohydrates fermentation occurring over there. Once the carbohydrates fermentation occurs over there, we have the gas production and the tissue necrosis happening. So what is the gas that gets produced over here? It is hydrogen and carbon dioxide. This causes distension of the tissues, and then it causes crepitus and black necrosis, which further leads into septicemia, hypotension, organ failure. Okay, and then death if it is untreated. Okay, so this can actually extend it to thoracic and abdominal muscle. In liver, actually it causes necrosis plus frothy blood, and it is characteristically known as foamy liver. Okay, now I'll be learning about the clinical features. So first thing that we need to know, that is incubation period is 1 to 2 days. And what are the features that we see over here? So we see pain and swelling. Okay, so pain and swelling is very common. Then we have the skin discoloration. So the skin may turn pale, brownish red, or khaki brown due to hemolysis. So there is actually few levels of color changes that I would like you all to know. That is, if it is an early infection, no, we will be seeing a pale and white color. Why? Because it occurs due to the decreased blood supply, that is ischemia. And when it turns reddish in color, that is erythema occurs over there. It is because of the inflammatory response or the infections, or as infections spread. Okay, then we have the progressive infection. So how you will identify the progressive infections? When it goes into dark blue, dark purple or blue in color, this actually is caused due to vascular damage, hypoxia, and hemolysis. Then if we have the bronze discoloration, that is the khaki color. Okay, that is the classical sign of the clostridial myonecrosis. Then we have the blister formation. Formation, that is hemorrhagic bullae due to toxin induced vessel damage. In the advanced stage, that is tissue necrosis, there is a blue or greenish black color, that is it shows the extensive necrosis and the tissue death. Then we have the foul smelling discharge at the last, that is brownish with gas bubbles, and this gives the crepitus over there. Okay, so blisters and the discharge, that is the formation of the large blisters filled with foul smell is found over there. Then we have the crepitus. Okay, crepitus can be felt over the region. And then there is systematic symptoms, that is fever, tachycardia, sweating, jaundice, and hypertension. Then if there is oliguria over there, it signifies renal failure. So this can also infect the limbs, abdominal wall, appendix, gallbladder, common bile duct, intestine, uterus, and because in uterus it occurs mainly if there is a septic abortion. Okay. So now we'll go for the lab investigations. The lab investigations that we're going to do is the first one, what we do if it is a bacterial cause. So firstly what we'll do is we'll go for CBC. Okay, we'll go for CBC, and then when we see the CBC we'll be finding that leukocytosis has occurred due to the infection. Then we'll go for serum creatine kinase. Why? If it is elevated, no, we will be seeing it will be a cause of muscle destruction. Okay, then we have the serum lactate and the blood atrial blood gas. We would be doing that investigations. They will be finding metabolic acidosis, lactic acidosis. Why? Because of the tissue hypoxia. Then we will go for the gram staining. Okay, when we go for the gram staining, you'll be seeing something like this over there. You'll be seeing gram positive boxcar shaped bacilli. Okay, what is the shape of the bacilli? Boxcar. And you'll be finding no neutrophils due to the toxin induced immune destruction over there. We will be going for the Nadler reaction for the culture of the wound. Here what we do is, it's very simple. We'll be growing a culture media along with 20% of the human serum in a plate. So an antitoxin, you can see over here, is placed. An antitoxin is placed over here, and there is no antitoxin is placed at one half of the bacteria grown plate. So the zone of the opacity will be seen in that half of the plate where there is no antitoxin, that is this plate. This will be the zone of opacity. And in the other half of the plate where there is antitoxins, there is no opacity, and you'll be seeing that there is a this is actually the Nagler's reaction over here. Then we can also give LFT and blood urea for the investigations. Then for the imaging study, if you see over in the x-ray over here, you'll be seeing that gas is present in the muscle plane or under the skin. So this is, you can see over here, gas is present over here. And then when we go for the ultrasound, we go for the POCUS. It's also known as POCUS. For the POCUS, you'll be seeing that there is a subcutaneous air with dirty shadowing over this portion. If you can see properly, it is an air filled dirty shadowing. And then you can also see soft tissue edema over here, which is also known as cobblestoning. Okay, then we have certain special investigations. So what is the investigation? And we can also do the CT scan and MRI scan. For the CT scan and MRI, you'll be seeing the gas formation and the extent of the necrosis. This is actually useful in if you have chest or abdominal wounds. Okay, so next we'll be learning about the special investigation. So what are this? We can do anaerobic culture and toxin detection. So it can help us in identification if it's a clostridial species. We can also go for histopathology of the degraded tissue. Okay, so what we do over here, what we find over here is we'll be seeing muscle necrosis without the inflammatory cells, and gram positive bacilli is seen under the microscope. For the additional test, what we do is, for risk factors and complications, we'll be going for the renal function test. So renal function test, if it is positive, then what we like, if the levels are increased, we'll be assuming that acute kidney injury has occurred if it is a septic prognosis, if sepsis actually progresses. And then we have the coagulation profile that will be doing the prothrombin, INR, APTT, and it is done for to know if DIC has occurred in severe cases. Then we'll be going for the blood glucose and the HbA1c, that is why to check for the diabetes mellitus. So how can you prevent, how can you do the treatment? So firstly we do emergency resuscitation and supportive care, and then we go for the emergency resuscitation and supportive care. What we do is we give them IV fluids and electrolytes so that the patient don't go into organ failure or septic shock. And then we go for oxygen therapy, so this improves the tissue oxygenation. And we go for the pain management, that is we give them IV opioids, most commonly we give morphine. Okay, and then we go for the Monitoring. So monitoring vital signs, urine output, how much we need to maintain, 30 ml per hour and 0.5 ml per kg per hour. Then we need to maintain the lactate. We have to check for the, or the monitor the lactate levels for the sepsis. Okay. Then we have the antibiotics. So for the antibiotic treatment, what we do is we give them injection of benzyl penicillin along with metronidazole and injections of some glycosides. Then we can go for fresh blood transfusion. For the surgical intervention, we usually go for debridement, that is, we remove the dead cells, and it is performed to prevent the cells of the infection. And in severe cases, what we do is we go for the guillotine amputation, and then we go for the hyperbaric oxygen therapy. So it involves, what it does is it involves the breathing of the pure oxygen in a very pressurized chamber. So this, what does this do is it prevents the further bacterial growth. That is, I told in the pathogenesis it needs an anaerobic environment. So by giving oxygen, we're giving them an aerobic environment. So this controls the bacterial growth and it promotes the healing. We can also give them supportive care like pain, fever and shock symptoms management. So what are the complications? So this can further lead into septicemia, toxemia, renal failure, liver failure. Then we can also have circulatory failure, DIC, second infection, and if not treated on time, it can lead to death. So what are the preventive methods we can do is we can do the proper debridement of the devitalized crushed wounds, and the devitalized wounds should not actually be sutured. And then we have to do adequate cleaning of the wounds with hydroperoxide, and we have to give penicillin as a prophylactic antibiotic. Next, we'll be learning about diabetic foot and diabetic gangrene. So we follow the Meckett's classification of the diabetic foot. So in grade 1, what happens is there is no open lesion. In grade 2, we have a superficial lesion over here. In grade 1, we have superficial lesion. In grade 2, we have a deep ulcer. And in grade 3, we see abscess and osteomyelitis. In grade 4, we find that partial foot gangrene has occurred. In grade 5, whole foot gangrene occurs. So what is the pathogenesis? Pathogenesis, actually it involves three parts, that is neuropathy, vascular insufficiency and secondary infection. So from neuropathy, what happens is the patient loses their sensory senses, they lose it, and then we have the motor neuron dysfunction and autonomic dysfunction occurs. This leads into diabetic foot ulceration. In diabetes, what happens is vascular insufficiency occurs. Vascular insufficiency leads to ischemia and impaired wound healing, and this leads into diabetic foot ulceration. For secondary infection, what happens is inflammation occurs. Then it causes, once the inflammation occurs, there is an impaired wound healing and reduced angiogenesis occurs, and this leads to diabetic foot ulceration. So what are the clinical features? When you go for the diabetic foot ulcer, you'll be seeing that neuropathy symptoms, that is loss of sensation, tingling or burning of the feet is seen. The ulcer characteristic that you see over here, it would be open sores, often at the soles or the pressure points of our leg. Okay, with varying depths. So the infection sign, the first sign that we need to notice is there will be redness, swelling, warmth, and then a discharge from the ulcer. So there would be delayed healing. Why? Because of the high blood sugars and the poor blood flow over that region. Then it can cause foot deformities such as foot shape like claw toes and charcot foot. So next we have the gangrene. Okay, so how does this diabetic gangrene look like? It causes tissue death. So there will be black and dry or shriveled skin. If it is a dry gangrene over there, like over here, you can see over here, it's something like a dry gangrene over here can be formed, or it can be forming something like this, ischemic toes like this, and neuropathic or infected diabetic foot ulcer over here like this as a wet gangrene. You'll also find pain or numbness based on the type and the severity, and systemic symptoms, you'll be seeing fever, chills or sepsis in severe cases. So what are the investigations we're going to do? For the diabetic foot ulcer, we'll firstly go for the blood test. So what are the blood tests available over there? We have the random blood sugar test, fasting blood sugar, postprandial and HbA1c. We'll be doing those tests to check the blood sugar levels, and also we'll be going for the infection marker, example white blood cell count, C-reactive protein, and the kidney function test. Okay, and then we'll be and for the kidney function test. Okay, and then we'll be going for the wound culture. So if the deep tissue sample, it will help us to identify the pathogens that's involved in this, and it would help us to guide for the antibiotic therapy. So firstly, every time we need to first start with the patients with antibiotics if it is something related to bacteria and all, before we go for any surgical procedure. Firstly, we try to maintain it, we try to bring it down. If it's not possible for us to control, then only we go for the amputations and all. Then we have the imaging. So imaging, what we do x-rays to detect if there is any bone involvement. Why? Because it might lead to osteomyelitis, and we have to assess the structural abnormalities that has occurred. Then we go for the vascular studies. How we do the vascular studies? We either go for Doppler ultrasound or we go for the angiogram. This helps us to evaluate the blood flow and detect the peripheral artery disease. In gangrene, what we do is we go for the clinical examination. We assess the tissue necrosis and the systemic symptoms. Then we go for the imaging like MRI or CT scan for detailed visualization of the affected areas and to know the extent of the infection. Then we go for the blood test. So what we do in the blood test, we monitor the infection severity and the organ function. And if required, and to rule out malignancy, we need to take the biopsy or the tissue samples. Then how we do the treatment? So firstly, it won't be directly gangrene. It would be firstly starting with the diabetic foot ulcer. For the diabetic foot ulcer, we'll do firstly the wound care, that is regular cleaning, debridement and dressing changes. Then we have the infection control, that is antibiotics for the bacterial infection. Then the pressure relief will be given, that is we can use certain orthotics or specialized footwear that reduces pressure on the ulcer. Then we have to manage the blood sugar of the patient, which causes tight control of the blood glucose level to aid the healing. And then we go for the surgical intervention in severe cases. For example, we go for procedures like skin grafting or amputation if it's necessary. Then we go for the gangrene. Okay. So gangrene treatment, how we'll do the debridement. We'll remove the necrotic tissue surgically, and then we will be giving them antibiotics to further prevent and treat the infection. Then we'll go for hyperbaric oxygen therapy. Why? Because it gives more oxygen supply to tissue, it aids the recovery. Vascular surgery can be done. This is to restore the blood flow to affected areas, and then we can go for amputation in case gangrene is extensive and it is life threatening. Okay, now we'll be learning about the fournier's gangrene. So fournier's gangrene, actually it's an idiopathic gangrene of the scrotum. It is a vascular gangrene of the infective origin. Okay, if you can see over here, it's usually caused by hemolytic streptococci, microaerophilic streptococci, staphylococci, E. coli, Clostridium welchi, bacteroides, fragilis, and it is very common in diabetics, old age, malnourished, immunocompromised individuals. It spreads fast, uh, like by the cellulitis of the scrotal skin, and then it extends to the groin and often anterior abdomen. This over here, you can see over here, it has spread to the abdominal wall. Okay, so next we'll be learning about the pathogenesis. So what happens over here? So any sort of trauma, infection or surgery in the perineal or the genital area, it causes polymicrobial infection. It can be aerobic and anaerobic bacteria. This invades the tissue. This causes fulminant inflammation of the scrotal skin and subcutaneous tissue, which further leads into obliterative arteritis, which causes inflammation, and this leads into thrombosis on the occlusion of the arterial supply which supplies the scrotal skin. Then we have the ischemia. So what happens over in the ischemia is there is a loss of blood which leads into hypoxia and tissue death. Gradually it causes cutaneous gangrene, which causes necrosis of the scrotal skin with black and non-viable tissue, and if untreated it leads into systemic effects like fever, sepsis and multi-organ failure. So what are the clinical features you see over here? So the clinical features you'll be seeing local symptoms. So local symptoms means severe pain, swelling, erythema, and necrosis of the affected area is seen. And then the systemic symptoms will be seen as fever, tachycardia, hypotension, and signs of the sepsis. We can also see crepitus, which is actually a crackling sensation due to the gas in the subcutaneous tissue, and there will be extensive slowing which would cause the normal testes to be exposed. And if the toxicity is severe, we'll be seeing renal failure along with further complications and death if it worsens. So how do you do the diagnosis? In clinical evaluation, we firstly go with the history and the symptoms of the patient. That is, you'll be seeing the patient would be complaining with severe pain, swelling, erythema and necrosis in the perineal or the genital area. Okay. Then we go for the physical examination. You'll be finding crepitus, that is gas under the skin, foul smelling discharge, and systemic signs like fever and hypotension. When you go for the lab test, we firstly go with the blood test. So how we go with the blood test? We run for the WBC count, we go for CRP protein, and we also check for the markers of sepsis. We do wound culture so that we identify the causative pathogens, and then the blood culture to detect the systemic infections. For the imaging studies, we do an X-ray. So an X-ray over here, you can see this is an X-ray. It's to identify the gas in the soft tissues. Over here you can see it's a gas over the soft tissues. In ultrasound done, you can find ultrasound actually is done only to find if there is fluid collections and gas pockets present, like over here. Sorry, not over here. Useful for detecting fluid collections and the gas pockets. This over here, you can see that it provides the CT scan, it provides the detailed visualization of the extent of the infection and the necrosis. And then we go for the MRI. Okay, MRI, it often shows high resolution of the imaging of the soft tissue involvement. Then we go for the treatment. So mostly it is treated as an inpatient. Then we go for IV fluids and catheterization, which helps in the maintenance of the urine output. And then we give them antibiotics, blood transfusion if it is required. Then nutritional support is given, TPN or enteral method. And we go for the liberal excision of the slot. We do the skin grafting once the patient recovers and the wound granulates well. Then if orchidectomy, it's not actually necessary if the testis is normal and viable. So what we actually do is we keep the testis in the pouch in the medial aspect of the thigh, and then we try to dissect or remove the slaw from it. Then we have the internal gangrene. So internal gangrene is a very rare condition which affects the internal organs such as the abdomen, small and large intestines, etc. The causes is due to the lack of blood supply in conditions such as atherosclerosis or blood clots, infections such as bacterial infections which can lead to tissue death in organs, or trauma or surgery. So over here you can see this is a internal gangrene. Then what are the clinical features? So there are local signs, systemic signs, gastrointestinal signs, intestine is infected, and advanced signs. So in local signs, what you see is there is severe pain. That is, there would be an intense and localized to the area of the affected organ. Example in the abdomen for intestinal gangrene. When you go for the swelling or the distension, you'll be seeing that particularly in cases that involves the abdomen. Then you have the systemic signs. So fever and chills, tachycardia, hypotension. Why? Because this all indicates infection, inflammation, systemic stress and sepsis. Then we have the gastrointestinal signs. So for the gastrointestinal signs, we have nausea and vomiting. So nausea and vomiting, loss of appetite and abnormal stool. So blood in the stool actually, or any changes in the bowel habits, is an indication of gastrointestinal infections. So we can also see advanced signs like skin pallor or sinuses, that is pale or bluish skin due to poor circulation of the blood. And there can often be altered mental status, that is confusion and drowsiness if the case is a severe one. For imaging, we go for CT scans or MRIs to identify the affected area. We go for the blood test to detect the infection or organ disinfection, and biopsy for the tissue sample for confirmation. The treatment usually is surgical intervention. We have to remove the necrotic tissue of the affected organ so that it no longer spreads. And we can give antibiotics to control the infection. And the supportive care is we have to manage the sepsis and the organ failure. So that was all for today. I hope you like this video. If you like this video, don't forget to like and share to the channel. We'll be coming with more videos. Till then, stay tuned and happy learning. This is Ashnavraju signing off for today. Bye.